So I have divided it into some parts. Probably today I have only time to cover part 1. Okay. I will try to go fast, but it will take time because it's also an important chapter. So the remaining part will be taught in Wednesday, okay, in practical class with that day's topic. So HIV or AIDS. What is the etiological agent? That's a viral. That's of viral origin. But what HIV stands for? Human virus. What are the peculiarities about it? And what's the reverse transcriptase enzyme do? What's transcriptase do? And what's reverse transcriptase? DNA. That is the peculiarity. And another thing, is that aerobic or non-aerobic? Can HIV virus live in the open air? No. And HIV infection was first noticed in which animal kingdom? Which animal? Monkey. Correct. And first case I think in South Africa. Then, okay. Then as we know it, it is human immunodeficiency virus or human T-cell lymphotrophic virus third, HTLV3. If in your NEET PG or INICET, they do not use the HIV. They will always give the question as HTLV. Okay, to make you confused. The virus replicates actively dividing T4 helper cells. So what is its target? Helper T cell, helper T4, and uniquely destroys them. Usually what is the function of T4? To destroy foreign agents. But what it is doing? It is actually targeting T4 and destroying that cell, and that is actually causing immunodeficiency. And there is opportunistic infections and such as that. You all know that from microbiology. Okay. What is the site where we found this? In greatest concentration in blood, semen and CSF. And where it is the greatest concentration, these became the potential to spread, potential ability to spread to other people. That's why body fluids such as blood, semen and CSF are the source of getting infection to others, not saliva or sweat. They also contain, but the amount is too much less to cause any harm. Okay. Also breast milk, urine, these things also, this question has been asked. Okay, that breast milk is obviously a common choice because there is a short note also that is important to you, that what to do with a child of a HIV affected mother. What is the feeding regimen, what will be its treatment regimen, everything you have to know. So now coming to the host, it is mostly prevalent in reproductive age groups that coming to the 20 to 49 years. We are actually considering only the females. Gender, it depends on the region, as in North America and Europe and Australia, mostly men. Africa, the ratio almost equal. Same goes for our India. Okay. High risk groups, that people having multiple sexual partners, MSM and sex workers, IV drug users, transfusion recipients, blood and blood products, hemophiliacs and clients of STD. So they are actually high risk group, and also you will come to a new term, that is bridge population. Those who are bridging the normal people to these high risk people. Okay. Then who goes to, suppose you are taking sex workers, who will be visiting to them, whether it is male or female, it doesn't matter. those who are visiting to them, they are coming from the normal population, and they are going back to the normal population. That's why they act as a bridge between this high risk group and the general population. That's where the bridge population term came. Truck drivers, they are regarded as a part of this bridge population. Okay. What are the modes? Unprotected sexual intercourse, vertical transmission, that means from pregnant mother to the child, and injective drug use, whether, and also it contains IV addictive substance use. Okay. What are the estimated transmission risk? 95 in 100 or transfusion with HIV positive blood or blood products. If HIV positive blood get transmitted to 100 normal people, 95% of them will develop HIV infection. Okay. That's why when you will enter into your internship, you have to be very much cautious. Okay. If there is any needle stick injury or anything other that, you should test the patient for HIV. There are rapid kit is available. Always test the patient first. Okay. And what another infection you should be aware about? Hepatitis B. Okay. 1 in 4 for perinatal transmission, 1 in 150 in needle sharing. Okay. Rest are the too much higher. You have to remember this second one, perinatal transmission. It has been asked. Okay. Probably another thing we'll ask, but at least the first 4, these numbers are some low, so you should remember it. Or it can come in INICET as a matching question or grading that arrange this regarding risk exposure. Okay. What is the incubation? What is the concept of incubation period? What is the incubation period concept? What means incubation period? Appearance of symptom and signs. And what will happen to be previously? Get into contact or your entry. Okay. Or contact with agent and the host. Now, HIV infection and getting AIDS. What is the full form of AIDS? Acquired. So, the word syndrome actually encompasses multiple system involvement, multiple organ involvement, and sign and symptom to those. That's why not every HIV infected people will not develop to AIDS. Okay. That's why what is the incubation period of who will develop the clinical disease remain uncertain. Possibly 10 to 13% will develop AIDS. Okay. And what is the usual transmission or window period? 8 to 10 years. It has been asked in NEET PG multiple times. Okay. But how if there will be any carrier state throughout the life? No. Person will show the symptom at one time or another. Okay. The incubation period is higher, but it will show. There will be no carrier state where they will carry but will not any symptom throughout the life. There will be no permanent carrier state for HIV till now. Okay. And another thing, AIDS related complex. That is also a separate thing from the AIDS. It is actually AIDS related complex with AIDS and opportunistic infections related to AIDS. Okay. A person having AIDS, the symptoms and signs of AIDS, and other symptoms which is related to the condition is attributed to occurrence of AIDS. Okay. such as AIDS plus TB. AIDS patient nowadays TB and HIV tests are doing simultaneously in every patient. Okay, if the person get diagnosed with TB, he will immediately get diagnosed for HIV and vice versa. However, it is estimated that 75% of those infected with HIV will develop AIDS by the end of 10 years. It is estimated because the study is still going on. That's why 75% word is there. Okay. And now coming to the case definition. You have to remember the case definition for AIDS. Okay. Because on the basis of the case definition, the HIV sentinel surveillance or AIDS surveillance is going on. And HIV sentinel surveillance is an important short note in your exam. Okay. Sentinel surveillance तो what है? ये HIV sentinel surveillance. How much population from which group is taken and the surveillance how it is done. You have to know these things. Okay. So it is somewhat I think it does not written in Park. I will share you a note. Okay, because the question actually came. So what are the major signs? Weight loss more than 10% of the body weight. Chronic diarrhea for more than 1 month. Prolonged fever for more than 1 month with it might be intermittent or constant. What are the minor signs? Persistent cough for more than 1 month. Generalized pruritic dermatitis. History of herpes zoster, oropharyngeal candidiasis, chronic progressive or disseminated herpes simplex, and generalized lymphadenopathy. And how many symptoms has to be present? An adult or adolescent is considered to have AIDS if at least 2 of the following major signs are present in combination with at least one of the minor sign listed. So if a person comes to you, weight loss than more than 10%, prolonged fever for 1 month and persistent cough for more than 1 month, what will be your probable diagnosis? TB होते पारे. These are also the cardinal 10 symptom sign of TB. Okay. So if you see, I actually told 2 major sign and 1 minor sign, but it might be a TB. So always think about other diseases also. Do not go to AIDS and counsel the patient or tell the patient, okay sir, probably you have AIDS. Because in our society it will create a chaos. And there is expanded WHO case definition. Do not have to remember this, but see it. Okay, it is somewhat similar. And there are 2 types of clinical staging system: initial infection, asymptomatic carrier or AIDS complex, and WHO staging. Okay, for you only remember the case definition for AIDS surveillance. So sir, what is surveillance? First chapter or second chapter ही है. What is surveillance, sir? Before remembering or trying to ratify the definition, please understand what is trying to say, because what I asked, it's a important, explain why. Okay, the teacher will ask, or it come as an explain why question. The monitoring and surveillance are 2 different things. This is a normal clinical picture of a HIV patient, that there will be exposure, and in the y-axis it is HIV viral load. The more the viral load, and in x-axis there is time. From this first it will cause acute infection. What is acute infection? Following exposure, HIV replication increases, the viral load rapidly increases and seeds into distant lymphoid organs. That is acute infection. Okay, it might be asymptomatic phase. Your lymph nodes are getting attacked, T4 cells are getting destroyed, so there might be a infectious type. It might produce symptoms, it might produce fever. So this is the acute infection phase, and then comes to the plateau phase of the viral load, and we usually tell it as asymptomatic phase. This is the continuous clearance of abundant infected cells slowly depleting CD4 plus T cells. This actually is asymptomatic phase, later progresses to AIDS when the CD4 cell counts will come to low. Okay. AIDS related complex, the definition is there. It is actually taken from your park. Okay. That and what are the opportunistic infection? For opportunistic infection, you have to write either by this, this is by time and the appearance, or by genre, that whether it is viral origin, it is parasitic origin, or bacterial origin. Opportunistic infection, probably an important short note in your micro, but nowadays it also might come in your CM. Okay, 3 number, 4 number, it might come. So prepare this short note, prepare this as a short note, so you can write, and rather than enlisting and writing all the things, you try to group it into different things. It will look better in your answer script. Okay. Then you can forget about 1 or 2 things. Probably in viral you forgot to write the herpes simplex and herpes zoster. You only wrote herpes. But if you put it as a viral origin, it will create another impression in the examiner. Okay. This might help you in later, যেখানে তুমি হচ্ছে গিয়ে ঠিকমতো লিখতে পারোনি অ্যানসারটা, সেখানে হয়তো হেল্প করবে না। ইউজুয়ালি ও হচ্ছে গিয়ে অন্যগুলো গুছিয়ে লিখেছে, এটা হয়তো তৈরি ছিল না ঠিকমতো করে, সেগুলো লিখতে পারেনি, হয়তো একটু কম নাম্বার কাটবে। That is how examiner's thinking process goes. Okay. Now coming to the epidemics, that means in the world where the epidemics actually happens, and we have 3 types, that is low level, concentrated, and generalized. Okay, what is low level? Prevalence has not spread to more than 5% of any subpopulation and confined to only HRG groups. Okay, what is the concentration? Prevalence consistently more than 5% of subpopulation but less than 1% among pregnant women in urban area. So it is more than 5% but still concentrated to less than 1% pregnant women. So the future generation is still coming out safe. That means the population is actually, this high risk group behavior is actually more in number, but the disease is concentrated to them. That's why prevalence is coming as more than 5, because they are more in number. But normal people, the pregnant prevalence is still less than 1. That means there are breech population number is low, so there is no mixing between general population and this HRG people. And what is generalized? Where there are no distinction. This is firmly established in general population prevalence consistently more than 1% among pregnant women in urban areas. Obviously the 5% is always there, and now it is more than 1% also in the urban area. Now the condition of South Africa. Okay, where HIV is very dominant form, or some African other countries also. And in here you will also heard the term PLHIV, that is people living with HIV. Okay, actually we do not tell them you are high risk group. High risk is on behavior, they might or might not get contact with HIV, but those who are getting into already had HIV, we address them as PLHIV. Okay, people living with HIV. In 2019 there were 38 million, and among them 36.2 were adults, 1.2 were adolescents. Okay, and what UNAIDS said that 1.7 million in mean became newly infected with HIV in 2019. After that actually COVID hit and the disease notification rate dropped. That's why those data are not now reliable. Okay, again the counting has been started, and we are awaiting for the results. This is a HIV AIDS in India, and what in 1997 there was highest incidence. Okay, that was called HIV scare. In USA the scare came in the 80s. In India the scare came in the 90s. Okay, and actually one South Indian lady scientist first isolated HIV virus from the prostitutes of Chennai. Before that, our government was not ready to accept that India has HIV. The HIV cases was there, everything was there, but government was not sanctioning. If you anyone wants to read some medical discovery stories, please see how HIV got detected in India and how much obstacles or hurdles she has to cross to get her paper published. Okay, what are the incidents? That means what the incidents? Incidents means newer cases. So new HIV infections have been reduced by 40% since the peak in 1998. In 2019, around 1.7, and later other studies did not show. Now coming to the morbidity factors. Will every patient those got AIDS will die? No. Morbidity factor is also important. So AIDS related deaths have been reduced by 60% since its peak in 2004. And in 2019, around 690,000 people died from AIDS related illness. In 2004, what happened? First, NRTI and NNRTI complex combinedly, the use of NRTI and NNRTI started around 2004. Also, if you remember that time, that in 2004 actually NACO started giving advertisement in the TV. Okay, so people started to get into the therapy. There are some also ads. You can see that in the YouTube, that NACO ads. Okay, you all heard the Buladi. Huh? 1098 Buladi. অনেক আগের জেনারেশনের কথা বলে ফেলছি. Okay, you can see in the YouTube. Okay, it is there. Oh, what are the other stats? In 2019, 81% with HIV knew their HIV status. This is also important. Those who have HIV, they have to know that they have HIV. Okay, because just think, if a truck driver gets HIV from HIV affected prostitute, he came to his home, his wife, eventually his wife will also get infected. Now the prostitute got AIDS. Obviously the prostitute will be asked that with whom you have, probably she maintains a register or copy, these are my client list, and from there you got the truck driver, or the truck driver first get diagnosed. He will tell that I got to this and that. Who will be in the dark? The wife of the truck driver. Obviously the truck driver will not tell, obviously. So who will inform her that, ma'am, you already got HIV? That is also a thing. In India, that is a thing also that we have to think about. That's why 81% people, it actually came from a survey done by our central government, that 81% of the people who actually are suffering from HIV knows their HIV status. They actually didn't inform. They asked one HIV affected person, who are your partners, and how many of them you have informed. He said that I informed that, them and them. Who is left? This. That is how the study actually came. Okay. And obviously we are a poor country and we do not have access to costly pharmaceuticals. So among people who know their status, 82% were accessing treatment, because the access is too much hard. Okay, first there is stigma. Okay, then you are having HIV, and the drugs are not easily available. So you have to get into the, in our state also, if you have to have uninterrupted supply of this thing, where you will get it? That is only School of Tropical Medicine. Okay. Even in our in my internship time, two of my colleagues actually got exposure to blood. Okay, there in ESOT there was some scuffle, and two transgender actually came with huge cut on their back. Okay, and they were too much of a bad patient. They are, when we tried to sedate them, they will know we will not take sedation, this and that. And after my who was the PGT, he and two of my colleagues, they sutured their wounds. And obviously they got tested for HIV, and two of my interns, two of my colleagues, they were interns then, they did not know how to safely suture. They told that probably they got the needle in their own finger. Okay, when you give the suture after first bite, second bite, when you up the skin, you have to support the victim's skin like that. When the needle should pass through away from your finger. But if you are not practiced enough, experienced enough, the needle might touch your skin. So there was exposure, and I actually went with them to STM. When we asked in our hospital, is available post exposure prophylaxis, PEP available? No, go to STM. And there in STM we also got into the line with these PL HIV people, then collect for them, and they also continued their therapy. So that is the thing, that drugs are not easily available, and there is stigma. How much stigma? They are all came covering their face. Okay, all the patients, whether it is male or female, they came covering their face, so people cannot notice. The passerby cannot notice and ask, hey, what are you doing here in STM? Oh, then we got probably HIV. TB is also that acceptable. HIV, God, even the educated people avoid them. What is the third? That among people accessing treatment, 88% are virally suppressed. If you follow the regimen, that means another thing, coming to the drug adherence or schedule adherence. In TB also, like TB, how the drugs are given in TB? For how, if it's a weekly dose, for how many weeks the drug will be given? Either 2 or 4, 1 month supply দেওয়া হবে। এবার সেইটা হচ্ছে গিয়ে তুমি খাচ্ছ, টাইমেও খেতে পারো, নাও খেতে পারো, তোমার ইচ্ছে। টিবির তার জন্য we have some pill box. The pill box is called MERM. Okay, this is not in your syllabus, but to make sure the patient is eating the tablet or capsule, there is the pills are supposed to kept in a MERM box. Okay, the box actually send a reminder to the phone of the victim and also the central TB division that the drug has been taken or not taken. Means the drug is shifted from the box, and after that patient will throw it in the drain or eating it. That is not sure. This is the reason why previously we have dots, directly observed, but now directly observation is not going on. Okay, it is going on in some states it's not going on. Okay, so these are the 90-90-90. This is the NACO or India government objectives, that 90% of the people who are affected will be aware from their HIV status, of which 90% will be on treatment, of which 90% have to show viral suppression. Okay, viral suppression means the viral load will be low and the CD4 count, CD4 plus T count is getting increased. This 90-90-90 rule or 90-90-90 objective you have to remember. NACP 4 is actually following this. In NACP 5 the objective is changed, but in your park still the NACP 4 is followed. Okay, so you can write on that. Same like 90 actually 95 objective came. Okay, but in your park NSCP 4 I saw the NSCP up to NSCP 4 is written. So in your exam if you go by NSCP 4 it will be accepted. Now coming to the TB HIV co-infection. Why these are getting diagnosed together? You already know, because some of the signs and symptoms of AIDS is similar to TB. That's why we are getting diagnosed for both the things. And also AIDS is a huge immunodeficiency state. The person is suffering from a huge immunodeficiency state. And what is the most common infective disease in our country? That is TB. It's our national disease, believe it or not. Okay, so TB, and we also has the agenda previously that we will end TB by 2025. That's why thinking of these all the things, actually the TB HIV co-infection campaign launched, that every person who will get diagnosed with HIV will have to go screen for TB and vice versa. And here one MCQ or MCQ actually arises, which treatment should be begin first, HIV or TB? What is your thinking? TB, why sir? CD4 কাউন্ট বাড়ালে টিবি দিয়ে তো ঠিক পারবে না। Why টিবি যারা বলছো, টিবি কেন? টিবি কেন? হ্যাঁ, মরবিডিটি। এইচআইভি তে যদি নাও মরে টিবিতে মরবেই। টিবিতে মারার চান্সটা বেশি, সেই জন্য when the treating people HIV with tuberculosis, ATT should be started first, followed by ART as soon as possible, ideally within 2 weeks to 2 months, and also isoniazid preventing therapy. Now people who are getting HIV, they also receive, if they do not have TB, in the course of time they might develop TB, so they are put on isoniazid preventing therapy, actually now called tuberculosis preventive therapy or TPT, where every day 1 tablet of isoniazid has to be taken by them. Okay, along with which vitamin is sought, which vitamin is needed for isoniazid? This is the statistical scenario of India. The estimated adult 15 to 49 HIV prevalence rate has been declining in India since the epidemic's peak in year 1998 or 2000, whatever is called. The estimate for 2019 was 0.22%. Okay, and these are the population. How many injecting drug abusers? Now 6.26. Transgender 3.14. Men who have sex with men, that means MSM, that is 2.69. Female sex worker 1.56. Truckers 0.86. Migrant workers 0.51. These truckers and migrant, just like truckers, migrant workers also belongs to what? HRG or bridge? Bridge population. Okay, actually this part is made by me, and your actually things started from second part. How much time do I have now? 5 minutes. So I will continue this treatment and diagnostic part in the second. Okay, this one I think is somewhat will be easier. I will reduce some slide.